So we have landmarked the site in advance, both with ultrasound and anatomically, to get a better sense of where we're going to be entering. So we already have a good sense of where the axillary will be. Of course, we call this an ultrasound-guided subclavian, but technically it is an axillary vein. So first thing we'll do here is visualize the axillary vein and inject some local anesthetic just overlying the area. So what we're looking for here, of course, is your kind of anechoic vessel, essentially as a circle. That way it's in short axis. And normally, if you come out a little more distal, you'll see the artery and vein paired. So if we come out a little bit, here's our artery. See, it's pulsating. Okay, if we in fact add some color, we'll get a better sense of that as well. So there we go. There's our artery, and there's the vein. Okay, now we want to make sure that we're getting a nice sense here of the anatomy. So back to 2D. As we go more medial, okay, that's towards the sternal notch, or just medial in general, we'll see just the vein underlying the clavicle. So if you move more centrally, there we go. Perfect. Okay. So what we're going to do here is this is about 2 centimeters deep. And so when we actually go in with our needle, we're going to start 2 centimeters distal or lateral to where we're going. So we're actually going to freeze 2 centimeters distal to the probe, because that's going to be our needle track. So that's our kind of ultrasound-guided local anesthetic injection. Okay, so we've given it some time for this anesthetic to freeze. The next step, okay, we're going to be very careful here. Again, we're going to find the vessel. We know that it's about 2 centimeters in depth. So again, we're going to go 2 centimeters back or lateral and enter at 45 degrees in the same plane as the vessel. So actually, before we get started here, let's make sure our wire is in really close proximity for us to grab. So if the wire is in close proximity, it means that it's very easy for us to transition from cannulating the vessel to dropping the ultrasound probe to inserting the wire. Okay, let's proceed with the needle cannulation of the axillary vein. So we're going to go at 45 degrees here, and we're aspirating continuously. Okay. Usually I give my hand a bit of a jiggle. That way I can see on ultrasound that it's exactly where it is precisely. I think we're right on top. There we go, venous flash. Okay, keep it there. We can drop the probe now. Okay, and then we'll secure that needle. And now we're going to take off the syringe and then insert the wire. The wire should thread nicely, should be very little to no resistance to go in. Once it's in, we're going to take the needle out and leave the wire in, and we're going to ultrasound the wire to make sure we're happy. Those 3 little bars there mean 30 centimeters. That's a pretty good depth. Now we're going to visualize the wire in the vessel first. Okay, before we proceed with the next step, let's make sure it's going exactly where we want it to go. Starting from lateral to medial. We are seeing the wire here pass in the longitudinal plane. This can be a little bit tricky because this axillary vein does very quickly become a subclavian, of course, under the clavicle. So I think we're satisfied, especially with how the wire went in smoothly, that this will be in the correct place. Why don't we go ahead and proceed with the incision and then dilation and then the successful catheter placement or successive catheter placement. At all times here, we're watching to make sure we have steady control over wire. I never personally will drop the wire just because I don't want it to either fall out or to actually go inside the patient and become an endovascular wire. Now this, we'll have one hand securing the wire, the other hand will kind of push, but also kind of a general corkscrew of the dilator itself as well. Once this dilator comes out, you will need to exert pretty firm pressure over the insertion site because there will be more bleeding, of course, when it comes out. The best way to manage that is to place the palm edge of your hand over the surgical site, over the procedural site, and then carefully, gently bend the wire so it arcs over your index finger between your thumb and index finger. Okay, now we're ready for catheter placement. We've done a really good job here of controlling the wire at all times. Now we're going to slowly thread this wire backwards. We're going to make sure we don't totally cover the wire. That way, if we did that, we might lose control of the wire. So we're going to slowly feed that wire back, okay, to make sure we can actually pick it up at the terminal end of the catheter. Once we have secured it in our right hand, we can advance with our left on this one. Yeah, perfect. So this catheter can be advanced to the hilt on this one. Okay, we'll remove the wire. At all points, we'll make sure we put our thumb over the end of that hub just to minimize entrainment of air. At this point, we'll cover the port with a cap, and then we'll flush every one of those caps to make sure there's no blood and make sure they have a positive venous flash. And then we will secure the line next to the skin. And I'm going to show you a trick with these. If you take it out and then just squirt a tiny bit of saline out. Okay. So, and then I want you to hold it so it's like you're holding it upside down. Okay. And then you're going to pull out some of the air. The air will float to the top. So we're going to, we attached the flush here. We extracted the air. That's why the syringe is vertical. Now we're going to flush the line. Okay, that's the ideal way to flush the line to minimize entrainment of air. Perfect. Okay. And now we'll attach the site. The important thing that I'll emphasize here, just to end this video, is that we want to make sure we attach the correct part of the catheter. There is an extra device in the central line kit that you can use to secure the line. But typically, we like to secure the hub. If you can point to where the hub is here, to the two wings, yep. We secure those areas there. That makes sure the line itself is secured and won't come out of the patient. So that's it for here. You can also add lung ultrasound as well before and after as a technique to detect pneumothoraces. In this case, we'll do a chest X-ray just to verify endovenous placement. and rule out pneumothorax, but certainly ultrasound can be a technique to rule out pneumothorax post-procedure. Okay, that's it for me.